Hello, and thank you for attending our session, a tour of pragmatic methods and measures, planning your data collection strategies for electronic health records data. My name is John Rice. I'm a biostatistician with the CORDS and research assistant professor with the Department of Biostatistics and Informatics in the Colorado School of Public Health. My co-presenter, Carter Sevick, a data analyst with the CORDS, will be hosting the case study portion of this session. Our goal is to explain what EHR data is, what it can be used for, and some of the methods that are used to analyze it. First, what is EHR data? EHR stands for Electronic Health Record. Other terms include Electronic Medical Records, or EMR. EHR is an electronic or digital version of a patient's chart. It may contain data on many aspects of the patient's health, including elements of medical history, diagnoses, which often appear as codes, for example, ICD-10, medications currently or previously prescribed, and even images such as radiology results. The promise of EHR is to allow data-driven approaches to improving patient care, which can include streamlining clinician workflows. There are many ways in which EHR has been and continues to be used, both in clinical practice as well as research. This is a list compiled in a recent review paper on the topic of big data, meant to give an idea of the breadth of such uses. Pharmacovigilance is the process by which drugs already brought to market are monitored for adverse events. This can be faster and more accurate when conducted using EHR than using manual methods, such as chart review. Machine learning methods can be applied to EHR to look for keywords and phrases associated with adverse reactions to certain drug pairings. Phenotyping is associating certain disease characteristics with genetic patterns. Phenotypes identified using EHR can be analyzed to determine their association with risk factors, treatment options, and outcomes. Natural language processing, or NLP, is a set of biomedical informatics techniques used to extract and structure information from text. Much EHR data is unstructured, such as discharge summaries, written in narrative form without traditional markers such as variable names, types, etc. Information extraction is a particular use area of NLP, which is used to identify and classify concepts and relations from such text. Current research focuses on broadening the applicability of NLP from deriving information from single sources to draw instead from multiple sources. Data application and integration refers to the use of EHR to compare treatments and conditions closer to reality than clinical trials would be. This can also assess things like cost and quality of care. Emerging areas of research include integration of wearable device data and social media. Clinical decision support refers to the use of EHR to aid in improving clinical documentation, increasing adherence to clinical guidelines, helping predict outcomes, making diagnoses, and preventing errors. These use techniques from many areas of informatics and statistics, including neural networks and other machine learning methods. Examples include disease screening and hospital readmission prediction. Personal monitoring and social media refers to the application of mobile technology to healthcare, including wearable devices like Fitbits. There are thousands of existing healthcare-related apps of varying quality, such as smoking cessation and weight loss products. Research is ongoing into integrating this kind of information into traditional EHR. This could ultimately lead to more accurate identification of patients at risk of certain conditions. One important thing to consider with EHR is the question of data availability. EHR data is typically not collected for the purposes of research, so when using it to answer research questions, we must be aware of why and how it was collected. Another issue that can come up with EHR is the use of protected health information, or PHI. However, using de-identified datasets with certain identifying information removed, is often just as valid scientifically and can avoid some of the difficulties of working with PHI. What data is collected in the EHR is often dependent on things other than scientific rigor. For example, infant heights may be missing due to squirming or fidgeting during evaluation, but weights, requiring only that the infant be on the scale, may be more likely to be complete. When using billing data, it is important to be as aware as possible of local practices or motivations that could lead to missed coding for less expensive procedures or diagnoses, for example. In thinking about the availability of data, the form of the data is also important. Some information, even if technically numeric, may only appear in free text fields, such as discharge notes. This will complicate its use in any analyses. Aside from considerations about the availability of data in EHR, it is important to understand the meaning of the data that is available. This relates to how and why the data was originally collected. To carry out research using EHR, concepts must be operationalized. For example, diabetes can be defined by several lab values crossing certain thresholds within certain periods of time. Different operationalizations may create differences in meaning that could render the data inadequate for research needs. Clinical procedures and workflows can affect both availability and meaning of EHR data. Interpretation of diagnosis and procedure codes may depend on individual sites and even providers. Researchers need to be sure the data elements have the same meaning between providers and over time to carry out a useful EHR analysis. There are many important aspects to where, how, and why EHR data was collected. This is an example of metadata, or data about data. Information about the source of the data element can include, for example, whether it was collected from patient, clinician, or instrument, or if the information is from bedside, a local lab, or a central lab. Uniformity of workflow would include, for example, whether it is institutional policy to collect this data element. If not, then it may be more likely to be missing. Consistency of charting could include how and why data elements are missing or may be recorded elsewhere, such as in free text fields. Data cleaning and standardization issues of importance would include whether outlying values are removed from the record automatically or just flagged as anomalous. Each of these pieces of metadata can be helpful to the interpretation of results from an analysis of EHR data. Analysis using EHR data can be different from analysis of data from a randomized trial. For example, confounding can be a much bigger concern when comparing outcomes between groups using EHR data. More complicated and sophisticated statistical methods are required to deal with this situation. These are primarily either regression adjustment or propensity score methods. It is particularly important to avoid confusing association and causation in studies based on EHR data. Association may be measured in many ways, depending on the form of the variables and the type of relationship that is of interest. For example, correlation coefficients for continuous data or odds ratios for binary data. Causation means that changes in one variable directly cause changes in another, which can only be reliably established by random assignment to the conditions under study. Both regression adjustment and propensity score analyses provide methods to remove confounding bias when estimating the relationship between a given exposure and outcome from data that may not come from a randomized study, such as EHR data or other observational data sources. The specific statistical methods used will depend on the purpose of the analysis. Analysis of EHR is often performed for two purposes, prediction or inference. Inference is what we are using when we talk about p-values, confidence intervals, etc. Prediction can derive from a model also used for inference, but does not have to be based on an explicit model at all. This latter possibility is what is meant when the term black box is used in the context of data science and statistics. The goals of prediction are not to make statements about whether a difference between groups is real in the sense of not being due to random chance, but instead to generate a forecast of some variable's value based only on data known currently. Causal inference is used to make statements going beyond causation between variables, going beyond association between variables, to explain how changes in one variable cause changes in another. Randomized trials are considered the gold standard for demonstrating causation. Randomization, when done properly, removes the influence of all possible confounders, even those that could not be measured directly. Confounding of a relationship between x and y occurs when there is a third variable z that affects both x and y. Without randomization, we need to rely on statistical methods to address questions of causality. EHR data rarely derives from randomized studies, so these methods are often applied in this context. Traditionally, covariate adjustment is used to remove the influence of confounders statistically. This method works well when there are few covariates relative to the number of observations, but can run into trouble when the number of covariates increases. Propensity score methods are an alternative method that can offer more direct causal interpretations, but there are a number of assumptions that need to be verified for such conclusions to be valid. Additionally, these methods can be more complicated to implement than traditional covariate adjustment. A propensity score, or abbreviated PS, is the probability of receiving a particular treatment. In a randomized trial, this is determined by the randomization ratio, as in most cases, randomization does not depend on individual characteristics. In an observational context, such as EHR data, on the other hand, the probability of someone being in a particular group may well depend on other factors, which may also influence the outcome of interest. This creates a confounding relationship that PS methods attempt to address. In practice, propensity scores can be estimated using a logistic regression model. These models are not meant to be used for inference, so it is common to include many predictors. The idea behind propensity score methods is to achieve covariate balance in the sense that individuals with the same PS should have roughly the same distribution of that covariate regardless of treatment. Once propensity scores have been estimated, there are several ways in which they can be used to conduct causal inference. Stratification involves defining 5 to 10 groups on the basis of similar propensity scores. These strata can be defined either on pre-specified values of PS or on quantiles if one wishes to obtain equally sized groups. The overall treatment effect is then calculated by taking the weighted average across strata. An additional advantage of this approach is that it gives stratum-specific treatment effect estimates, which can reveal treatment heterogeneity. Analysis can also be conducted by matching study subjects and propensity scores. Often, this is done in a 1-to-1 ratio. Each treated subject is matched to a single control subject with a similar PS. Other ratios are also possible depending on the prevalence of treatment and control subjects in the sample. There are different ways of defining similarity for finding a match. The nearest neighbor method is common, sometimes with additional constraints such as that the difference between PS within a pair has to be less than some fixed value. This avoids pairing individuals who aren't similar enough to each other. Weighting, in contrast to matching, uses the whole data set. The analysis, such as regression modeling, is conducted as usual, but with weights assigned to each subject within the model fitting procedure. The usual weights correspond to 1 over PS for the treated cohort and 1 over 1 minus PS for the control cohort. There can be numerical issues leading to very large weights when PS is close to 0 or 1, so care may be need to be taken with the definitions. The propensity score can instead simply be included as an additional covariate in any regression models. This summarizes the effects of all other covariates on the treatment group membership probability with just one degree of freedom in the outcome regression model. Prediction is a common goal of analysis of EHR data, since it is often available on much larger scales than data from clinical trials. This can help with generalizability, although predictive performance is limited by the context. In other words, if you are attempting to predict something that is inherently highly variable, then having a large sample size won't help the accuracy of your predictive model. Regression models may be used for prediction, in which case the analytic goals of prediction and inference may overlap. However, more specific methods for prediction also exist. These include penalized regression, which induces shrinkage in regression coefficients to increase the generalizability of model performance. Multivariate adaptive regression splines, or MARS, represent a regression-like method that allows for the accommodation of nonlinear relationships and interactions between variables, while retaining some of the interpretability of more traditional regression models. Decision trees are a method of classifying an outcome variable using a flowchart-like structure. Random forests aggregate many such trees based on random perturbations of the original data. More on this momentarily. Support vector machines and neural networks are techniques from machine learning that may lack the interpretability of regression methods, but can in some cases attain greater accuracy. I'll now give a brief summary of 2 issues that may come with predictive modeling in general, which also apply to the case of EHR data. There may be any number of predictive models with very similar predictive performance. This issue is known as the multiplicity of good models. These may give very different pictures of the data generating mechanism. This means that if you perturb the data slightly, you may get a very different best model. One solution is to aggregate over many competing models. There are many methods to go about this. Predictive accuracy is in competition with model simplicity in general. An example is decision trees. These are very easy to interpret and may lack accuracy. To improve accuracy, we may aggregate the results of many such trees, trained on perturbed versions of the original dataset. This creates a so-called random forest. The random forest is less interpretable than a single tree, but more accurate. In general, more data is a good thing, but there can be pitfalls when presented with extremely large datasets, which occur frequently in the EHR setting. What is meant by large can depend a lot on context. For example, so-called big data may be wide, with many variables, long, with many observations, or both. Each of these presents different challenges as well as opportunities. In the current context, I'm referring primarily to long data, which often results from combining EHR datasets from many institutions. This practice can lead to clustering, where variables measured within the same institution are more similar than our observations taken at different institutions. This creates a problem with correlated data, which may or may not need to be addressed in a particular analysis. However, inference may be effective if statistical methods fail to take into account this correlation, but prediction might not be. Computational considerations become more important with large data sets, and these can limit available statistical methods. For example, in dealing with clustering, we often fit generalized linear mixed models, but this is computationally demanding and therefore may be infeasible with very large EHR data sets. Another problem that can occur with large numbers of observations is a proliferation of statistically significant findings. With a large enough sample size, as long as the true effect is not null, p-values will become significant. However, this does not imply that the effect is clinically significant. It is important, therefore, to define a priori what a clinically meaningful effect would be. Then appropriate inferential methods, such as confidence intervals, can be used to understand the magnitude of the effect. Having a large sample size will enable more precise estimates or with smaller confidence intervals of these effects. At the other end of the spectrum, EHR can result in very small data sets. In particular, EHR can be helpful for studying rare diseases. You might need to cast a very wide net in order to get even a handful of patients with a disease of very low prevalence. Small samples can require the use of specialized exact statistical methods, including Fisher's exact test for categorical data or the t-test for normally distributed data. Samples may also be deceptively small in the event of clustered data. Even if the overall sample size number of patients is large, you may be limited by the number of clusters. This talk was intended to give you an overview of the possible uses of EHR, statistical and analytic methods that may be applied, and the limitations of such analyses. We need to be careful about interpretation when analyzing EHR data. It's important also to always involve a statistician early on when you're designing any study, including those using EHR. Thank you for your attention. I hope you've enjoyed this talk.
Hello, welcome to the case study section for the seminar on electronic health records data. My name is Carter Sevick. The example data we'll be using is provided by the Centers for Medicare and Medicaid Services, called the Data Entrepreneurs Synthetic Public Use File. It is based on a 5% sample of Medicare participants from 2008, which was used as a basis to generate random records that would be very similar to what one would encounter in an actual Medicare extract, but not be identifiable. It's also an excellent example of what one might typically see when analyzing an extract from an EHR. To save on storage space, the set was divided into 20 samples, constructed so that any given participant would only appear in a single sample. So, if you only need a small example, one sample may be sufficient. In this example, we'll just be looking at sample 20. Over the following slides, we'll take a look at some of the programming that went into the analysis. Just a small amount, however. Even a small analysis like this can be fairly lengthy. The data import alone was over 200 lines of code. The SynPuff is divided into 8 comma-separated value text files. Data exported for analysis may be a single table, or even more tables than the SynPuff. For example, the inpatient claims data has 10 columns for diagnoses and 6 for procedures. However, in other data sources, such as the Colorado All Payers claims data, diagnoses and procedures tied to an encounter are included as separate tables. Unfortunately, it is typical that an extract from an EHR will not necessarily include all information to fully understand the data that you are given. For example, in the SynPuff inpatient claims data, diagnoses and procedures are recorded using the International Classification of Diseases version 9. So, if someone had a toe amputated, this would be recorded as a procedure 8411, but the words toe amputation are not included in the data. Fortunately, CMS provides downloadable lookup tables, and many other useful tools for understanding these codes can be found on other websites, such as AHRQ's HCUP website. If you analyze professional claims, you will also run into common procedural terminology, or CPT codes. While you can usually Google them on an individual level, they are proprietary to the American Medical Association, and a small fee is required to get a complete lookup table. Many professional organizations exist for the study of various conditions, and many times they create validated case definitions that may be used on your analysis, or at least make a great jumping off point. For example, if you're interested in birth defects research, the National Birth Defect Prevention Network is one such organization. Also, if you work for a hospital, take the time to make friends with the individuals working in the billing department. Understanding these codes and how and when they apply is their livelihood, and they can be an invaluable resource. Of course, what we're looking at today is to show a little bit of what one can expect in analyzing an EHR data extract, and is not a rigorous publishable study. For this example, we're trying to extract some information about patients that have had a spinal fusion, including an estimate of how many will be readmitted to the hospital in the 60 days following discharge. Spinal fusion will be defined as an inpatient stay with a procedural code from 8100 to 8109. What we would like to see is the index surgery that an individual has. In your data extract, what you'll see are the encounters that the patients had in that system, but this may not be all their care. For example, the SynPuff data includes individuals participating in Medicare in 2008 and tracks them in the system through 2010. Where were they before 2008? Probably still in Medicare. But in this data, I have no visibility of what happened before that. This may not be their first surgery. Perhaps other vertebrae needed to be fused prior. Or perhaps they had a fusion on December 1st, 2007, which failed, and then they came back in January, and that is the initial surgery that we see. This small script was written in SAS programming language. We'll be looking at a small amount of this over the next few slides. I know not everyone watching this is a coder, so we'll not dissect this code rigorously. But even if you're not the one coding the data analysis, it's good to show that there is no easy button for producing an analytic file. At the top, the 66,514 records of the inpatient claims file is read in, the procedural columns are grouped together, and searched for codes defining spinal fusion. If one is found, a variable called SpineFuse is set to 1, otherwise left as 0. The next two blocks of code are written in standard query language. Academics will most often call it SQL, while database administrators in the trenches will refer to it as SQL. This is a powerful language based on set theory and is the workhorse of the database world. Here, we want to find the first visible fusion each patient has, This is accomplished by subsetting inpatient claims to only those records with a fusion procedure, then further subsetting to the record with the earliest date for each patient, which results in the table First Surge Rec with 536 patients. To ensure we have enough lead time to have a reasonable chance of seeing individuals' true index record, and enough follow-up time, more than enough in fact, to look for subsequent readmissions, the data is further subset to initial surgeries only in 2009, which yields the table First Surge Rec 09 with 207 patients. It is not a bad idea to look at diagnoses that go along with individuals under study. Here are the top 10 diagnoses among the 207 initial surgeries. Not surprising, the top diagnosis is actually hypertension, as the Medicare population is a little older. Also not surprising is a variety of spinal issues which may have driven the decision for surgery. But also a little further down the list are a few diagnoses that indicate that the surgery may have been due to a fall. Are these subjects of interest to the study? Or do we just want to look at individuals with a particular spinal issue? Based on what we have seen, we'll add a couple of indicators to help get a good idea of the subjects in the data. Codes that begin with 737 indicate spinal curvature, such as kyphosis, and these E codes indicate that an accidental fall may have occurred. Next, we'd like to look at our 207 subjects and link them back to the inpatient claims to see if they have a subsequent inpatient admission in the 60 days following the index discharge. In the from clause, we are joining our index subject data, which will be referred to as index, to the inpatient records, which will be called next. The inner join indicates that records from both sets will be kept that match on the unique subject identifier. The where clause specifies that only found records will be kept if the joined next record occurs at least 1 day after discharge and up to 60 days. The having clause further reduces the set to the first observed readmission. This process will net us 19 readmitted individuals. Here again, we can look at diagnoses associated with readmission. Finally, the disparate bits of information we've collected need to be brought together to form a unified analytic data file. From the beneficiary data, we take sex, race, and date of birth to calculate age at admission. Sometimes such information can also be found on the encounter records themselves, but care should be taken here. Often, not always, this type of information will be what was recorded at the time, which may have been an error. A person table, such as the beneficiary file, will usually be kept more up to date and has a better chance of having corrected information. Additionally, from the index admission record, length of stay is calculated and our condition indicators are retained. Finally, from the associated readmissions, an indicator of readmission is added, as well as a calculation of time to readmission. Next, we'll summarize the findings. Of our 207 patients, about 9% have a readmission in the following 60 days. Readmittees were more likely to be male, 12 versus 7%, a little older on average, 74 versus 73 years old, and have a slightly longer initial stay on average, and more likely to have a spinal curvature. Also, among those readmitted, the average days to readmission were 28, with a standard deviation of 17.4. I hope this has been a beneficial primer on some aspects of what you may see in the future. Thank you for your attention.
Okay, so we've stopped the screen sharing, and so we'll invite our presenters, Carter and John, to go ahead and answer any questions that may have come in.
Everyone, thanks for attending. So we've actually got a couple of questions in the chat already. So someone's asking, can the EHR coding and analysis be done in Stata? I am sure that Stata can accomplish these things, but I work in R and Carter works in SAS and R, so I'm not sure we're going to be able to fill you in on that. Carter, do you have any thoughts on Stata?
I've never really used Stata, but I do know that a lot of very good research has been done in Stata, even from the raw level of collecting data and producing analytic sets. So yes, Stata can do that. The only thing that I would say, and again, my knowledge of Stata is fairly dated, so I might be wrong in what I'm about to say, but at least at the time, one of the limitations that Stata had was pretty much the same as R, that if you're going to work on a table, it had to be fit into memory. So if you've got a really big amount of data coming in, hopefully you have enough memory. But of course, it's possible that they've fixed that since then. But of course, SAS, as long as your hard drive is big enough, you can fit it.
Yeah, I think that's a good point, Carter. I've run into problems with big data with R, and I know I've heard that SAS is better able to handle that. So you haven't run into situations that were too big for SAS to handle?
Well, not for data processing. Again, because it doesn't use for that kind of action. SAS doesn't use your RAM, your memory for that. It just uses your hard disk space and reads and writes. That's where your workspace is located, which of course on, I think my personal laptop that I bought for myself has like a half a terabyte. So that'll be good for just about anything. But not now for statistical analyses, that may or may not be true. So for a lot of analyses, like if it's a very heavy matrix procedure, like if you've got a multi-level model with several levels of nesting, the matrices that are needed are going to get very large very quickly. And I have run into problems with SAS memory with that, because in that case, yes, it uses your RAM in order to fit those models. SAS does have a suite of high performance procedures like HP mixed, which is the high performance version of the mixed procedure, which is much better with memory. And they have several of those types of procedures available. Don't know them all, however.
Yeah, that's another good point. So I guess the answer to the question is that, you know, there's different statistical packages have different strengths and weaknesses. And, you know, as Carter's just explaining, I think SAS has a lot of facilities that make it helpful for dealing with at least the data processing step, as well as the analysis for large EHR data. And again, you know, unfortunately, neither of us are as familiar with Stata. But you know, I'm sure that you know, the documentation typically for these, you know, packages is very good, and well referenced as well. So I think that's a good place to start if you have questions about specific software. So Preeti has another question. Is provider level information available in EHR? And that's another good question. And, you know, it's an answer that's probably going to be a common theme. It depends on the source, really. So I think that there are often EHR data sets that do contain provider level information. But, you know, it really depends. I mean, I was working recently with the APCD, and we were interested in prescribing behavior with respect to opioids. So it was Colorado data. Anybody who had been prescribed a particular class of opioids within a certain time frame. And the problem we ran into was that it was hard, if not impossible, to link records to specific providers because just the way the data was structured. So, if it's billing data like that, then it's at it's at sort of the transaction level or the claim level. So it's some of those records are tied back to a provider, but it might not be the provider that you're interested in. For example, in these cases, I think sometimes the provider was recorded as, it may not have been the prescriber, it may have been the patient's general provider. So, there's a lot of issues like that. And again, it goes back to the fact that when we're using these data sets for research, it's not the purpose that the information was collected for. So that's one thing to be aware of whenever you're analyzing this type of information, this type of data. So yes, there are cases where provider level information is available, but you do have to be aware of the limitations, and especially which provider which provider corresponds to each record in your data set. Carter, I don't know if you have anything to add to that.
Just that many times the primary goal of the EHR is, of course, to keep track of what happened with the patient, but also its primary mechanism or reason for being is really to help facilitate billing. And so a lot of times that's really going to be what's required to submit a bill. And so like if you have, you may have, like, say, a set of Medicare records, Medicaid records, and for a facility, and the care could be provided by any number of people, but really what they'll want to know for the billing is like, okay, who is who's the billing entity? There may be only one billing entity for that facility, and so everything may be tied to a one person, even though perhaps the care was developed or given by somebody else. So just getting to know your data is important.
Yeah, I think that's very true, and all circumstances, getting to know your data. So Michelle has a question. When you are consulting on EHR-based research studies, what are your main questions for researchers? This is another good question. It goes back to kind of, study planning and, when we get involved in the particular project. So, again, we're involved consulting early on before the data has been pulled, because there are certainly freely available data sets, but many of these EHR data sets you have to pay. And that can be a laborious process for many reasons. So you want to be very careful about asking for the data that you need to answer your research question, because otherwise you're going back to the provider with more questions. And again, with the APCD in Colorado, I think they have it's just a long turnaround time sometimes to get data issues corrected. So I think key early on when we're consulting is just talking through with you exactly what your research questions are, and then what data fields are going to be necessary to answer those. So that's one thing, and the other thing is kind of defining your cohort as well, because this is another issue that comes up a lot with the HR data, is defining an appropriate control group. So I'm helping with a study design now that's trying to look at usage of the emergency department in the kind of COVID era versus prior to COVID. And the one of the issues that came up is a control group for that, because their group of interest is high ED utilizers. So that's one of the things that we were having to think through was an appropriate control group. And that's kind of ongoing now. So just kind of on the one hand, data fields that you need, so columns in your data set, and on the other hand, your cohorts. So which, what rows, which people are you going to pull from the data? Carter, do you have anything to add to that you would like to hear from collaborators?
Absolutely. I would say kind of one of the biggest things that I would like understood a lot is that, our analysts, your analyst is a mathematician slash statistician. And although, like myself, I've been doing this for 15 years, and in that time I have absorbed a lot of biological concepts, but at the end of the day, I'm a numbers person. And so, and I did have an interaction with a PI once where I gave them, okay, these individuals, you asked about the prescriptions, they have all these prescriptions, and like, okay, well, why don't you group all those for me and, turn those into biologically plausible groups of drugs. Like, I can't do that. Well, it's really simple. These things go with this, and these things, I don't know that. So understand that we're numbers people, and the experience of the PI and the medical expert are very important for us.
Yeah, I agree. I think that's a great point, because it is a collaboration, ideally, and again, we bring the statistical or the mathematical expertise, and you bring the clinical or the subject matter expertise. And so communication is really key. And just kind of as a small point, it's you don't feel shy about sharing like the full text of the grant with us, because sometimes we just get kind of a small subset of the grant text, or that doesn't necessarily contain, for example, the aims. And that can make it hard and I understand that a lot of time, collaborators don't want to burden us with too much to read, but we don't have to read everything, and having that available allows us to get a better sense of the context. And there's been several times when I've had some misunderstanding just because of the sharing of information wasn't sufficiently broad, I guess, to make me aware of all the nuances of the research. But so don't feel shy about that. But I think we're running out of time here. So if does anybody have any last minute questions here before we break? If not, thank you again for all coming and participating, and for your interest in EHR and statistics.
Thank you.